Hi everyone, I'm Dr. Kevin Johnson. I'm the David L. Cohen University Professor of Biomedical Informatics, Pediatrics, and Science Communication here at the University of Pennsylvania. I also serve as the Vice President for Applied Informatics at the University of Pennsylvania Health System. My work focuses primarily on how to build trustworthy, human-centric systems that can benefit clinicians, patients, and communities. I'm here today to talk with you a little bit about a problem that's near and dear to my heart, which is primarily how to reimagine healthcare in the ambulatory space using AI to improve the conversation between patients and clinicians. I went into medicine as a pediatrician because I really loved the relationship that we as clinicians can have with patients and families. I was a really major part of the movement toward electronic health records all through the 90s and the early 2000s. So you can kind of imagine how I felt when I started realizing that the electronic health record was a major force behind the epidemic of burnout that happens in these practices. It turns out that that burnout is adversely affecting primary care, including people's willingness to enter it as a specialty. My view of this has always been that the technology could be there to augment what we do in the ambulatory care environment, including supporting both the patient before the visit, during the visit, and after the visit, and helping us as clinicians to know what we've seen, what we may have missed, thereby augmenting what we may be doing during the visit, and what we should document, hopefully having us document nothing, and having the environment itself do all the documentation. So this has been a vision I've had forever, and I've always imagined the idea that I could be having a visit with my patient the exact same way I'm talking with you, and without the technology getting in the way of it. And so my goal now is to see to what extent we can pull the technology back from that view. We now have a number of technologies, including the very popular term ambient scribing, but also machine learning, tablet computers, and access to the same information in patients' home and community environments that we actually have in an ambulatory setting. We have better ways to give people just-in-time information from knowledge. We have ways to actually show videos. In short, we really have an environment that is tailor-made to augment the care that patients need at the time that they are seeing a clinician, or perhaps even before that time. My view of this has been that what's missing is the bridge between departments of engineering and social workers and what we do in healthcare, because healthcare as an environment is generally inaccessible. But I believe that by creating that bridge, we can move forward with reimagining documentation. So when I first came to Penn, I was lucky enough to receive funding to create what is called the Observer Repository. The Observer Repository is a series of videos, now totaling about 150 videos, of clinical encounters, in addition to all of the electronic health record data and patient satisfaction and clinician satisfaction surveys. So in short, it's the entire view of what happens during a clinical encounter. Using that data set, which is really one of the first of its kind, we've been able to start answering very interesting questions, including to what extent is ambient scribing impacting the visit positively or negatively? We're one of the earliest places to be able to do that kind of work. But we're also thinking more creatively about reimagining documentation. What if I see a walker on the video, but I don't actually see it in the EHR? Is it possible for me to create documentation automatically that talks about assistive devices? What if we actually hear from the patient signs and symptoms of mild cognitive impairment? My lab is now working on a series of technologies, primarily using AI and machine learning, to extract all of the features that are necessary to identify patients who might be at risk for mild cognitive impairment, with the hope that we'll be able to translate that into a very intelligent and precision screening tool that will be used in that environment. Well, what if we are dealing with the epidemic of loneliness, but our clinicians maybe don't have the time or even the knowledge to ask questions about something like loneliness, or maybe they know how to ask it, but they don't know how to treat it? What if we actually have other items on the agenda of the patient that we are not ourselves addressing? We've actually seen some of these questions arise through a group that we have called the Book Club, who are reviewing the videos and the data that we're collecting from the Observer Repository. So it's turning into exactly what I hoped it would be, which is a really rich hypothesis-generating environment. We're also building now a new machine learning algorithm with some colleagues from the School of Engineering, thinking about this issue of loneliness, using features that could be present in everyday conversation that we can map to risk factors for loneliness. And furthermore, using large language models to help clinicians who maybe don't know what to do to address the loneliness problem with some personalized information, maybe contextually based on where the patient may live or work. So we're able to use these new information in really exciting ways and looking forward to continuing to publish and hopefully change the face of medicine with this work. Thank you.